First, I'd like to say I found that first section fascinating. I think there's a lot more to health care than disease care. And unfortunately, we have a lot of patients that have very complex disease. And so part of this program was just to bring some of that to light. And typically, we will have a question and answer session after this, but you can see the enthusiasm from all the speakers, and it brought us a little bit past timing. So there was my anxiety right there, was keeping the program going. But we're going to move forward, and I really appreciate the first set of speakers. As speakers finish, I know you have busy lives, and you're absolutely welcome to continue with the program, or if you need to move on to take care of other patients. Thank you, Dr. Bailey. We appreciate all your efforts. So let's talk about, we're going to talk a little bit about PAD as a whole section. And my first thing is, PAD, be aware, what's the latest data? So I'm with VIC. Our passion is saving limbs, renewing lives. And as a circulation doctor, one of the things that I've recognized here, and as other doctors visit here, the density of disease is tremendous in this region. We are living in the stroke belt, the aneurysm belt. We are living in a region that has extremely high amputation rates from PAD, a lot of chronic disease, and poverty and lower education as a whole. And so part of that all mixes together, as Dr. Bailey showed us. But I want to emphasize what PAD is, and if we can start to recognize it a little bit more, we can start to catch people before they get into that disease state. So PAD is a marker for death with a 1-year mortality or major cardiovascular event rate of 20%. So when someone has PAD, 1 out of 5 is going to have some kind of bad thing happen to them every year. The problem with PAD is that it's ubiquitous. It's really kind of everywhere. So we experience this when we see patients that, yes, their diabetes is out of control, we've got to fight that, and their smoking's an issue, and maybe they have high thyroid, and we got to deal with that. There's issues that we all have to deal with, and there's a time constraint to get that all taken care of. But if we can start to recognize that what the signs and symptoms are of PAD, we can actually start to treat some of these patients. So part of this is just to change the mindset a little bit and try to bring some awareness to what this means. So on the bottom of this slide right here, as we go towards the right, we are having more and more disease to where we have unreconstructible vascular disease and lose a leg. And so outcomes get worse the more disease progress there is. And so the only way to actually fix this, is to start to identify people on this side where they have no disease or very little disease. And that's where we can actually start to change outcomes and get people on the proper therapy. If you had a patient that's diagnosed with PAD and you now have the ability to say, okay, look, you're in a different category, and we're going to be really aggressive with your smoking, and we're going to talk about it, and we're going to talk about your cholesterol and some of the other major drivers. But the main issue behind PAD is what we call endothelial dysfunction. So the endothelium is the inner lining of all of the arteries and veins in your body. And if I were to, it's actually the largest organ of the body. It has a metabolic function. And if I were to lay that out onto a field, it would be the size of an Olympic-sized soccer field. That's how big the endothelium is. And it protects you from the outside world. There are a lot of things that shoot at the endothelium, a lot of things that can damage the endothelium or inflame the endothelium. Smoking is one, high sugar levels is another, but those things can start to damage the endothelium. And over time, just living, we start to develop plaques within our bodies. That's a process of slow decline in endothelial dysfunction over time. But things that can accelerate that is the smoking risk. And so even currently, we're still about 20% as a population in this region smokers. It's a little bit higher in the American Indian populations, but by demographic, we're still fairly high rates of smoking. Now, obesity in children and adults is on the rise. This continues to be an issue. It has to do with what we eat and how we exercise. And we can see that this is significant. And it's significant because there's a correlation between obesity and diabetes type 2. And so if we have high levels of diabetes in this first column, 9% of Americans are diabetic, and there's about 3 to 4% that are diabetic, but they don't know it. So that means they're not being treated, and so they're constantly being challenged and damaged because of this. Hypertension is another major problem. This is the biggest driver of damage for the cardiovascular system. And currently in Hamilton County, right here, 1/3, 35% of all adults are hypertensive. That's impressive. Half of those are not on proper medical therapy. They're being damaged because of the hypertension. And so all of this leads to problems with heart disease as the #1 cause of death, stroke disease as number 5, leg amputation is the #1 cause for losing a limb. And PAD has a lot of different faces of PAD, where it can affect the circulation in the legs, where there's claudication or rest pain, or gangrene or embolization, but it also can affect the kidney function, develop of aneurysms, of stroke, of heart attacks, and there's a definite connection between lung cancer and PAD with the smoking that seems to be rampant in both groups. So PAD is a marker for death with a 1-year mortality or major CV event rate of 20%. If we can find these people early, we can start to change that. So if we looked at some of the data under the different studies that looked at how do we define, the partners group looked at a primary care population, and they said anybody that's over 70 years of age or anybody that's over 50 that is a smoker or diabetic. We're just going to look at just that group. And if we looked at just that group, 29% of those patients had PAD. And they determined that by a simple ABI. They checked the blood pressure of the arm compared to the blood pressure of the ankle. If it's 0.9, it's the ankle over brachial. So if the blood pressure is lower in the legs, if it's 0.9, then you were positive for PAD. And half of those people had PAD and also coronary disease. So that would be interesting to find in your population and say, okay, I have a simple test, very simple test, to determine is this person at high risk of a heart attack or a stroke or losing a leg. Now, interestingly, in this group, we had about, if we look at the blue, in the newly diagnosed PAD group versus the group that's already known to have PAD, most of these people, or about 25% of these people had no symptoms, 50% of these people had no symptoms, and then the vast majority had non-specific symptoms. They had some cramping or some weakness or things like that that people describe. But the vast majority of patients are asymptomatic for the disease. Now, only about 20% of the patients actually had claudication. That's when you have that walk, rest, walk cycle, and you have pain in the calf when you walk, and then you have to stop, and then you can rest for a few minutes, and it comes back. That is a vascular problem. That's not orthopedics, that's not nerve, that is a vascular symptom if they have a walk, rest, walk cycle. But only 20% of those had claudication. The other patients had weakness, or they had leg fatigue, or they described it differently than pain. And so that's the one thing about patients is you have a lot of different symptoms that might suggest PAD, but it's not a hard symptom to say, yes, you have it. It has to trigger something in your mind that say, hey, maybe you need to be tested for this. So if we do that test in the ABI and we get down to 0.9 and we get down to 0.8 and down to 0.8 here, the lower your ABI, 0.7 here, the lower your ABI, the higher your mortality. There's a direct correlation. So that simple test is very predictive of people that have PAD and their mortality risk. PAD likely is a metabolic disorder of calcium. So we tend to calcify arteries. The patients that tend to calcify the most are those with advancing age. This group is rising. That's what we want. We want to live longer. Diabetics, there's more diabetics now than yesterday. Kidney disease is more prevalent now. So we think the latest data, putting it all together, is about 21.3% of Americans have PAD, and more than half of those patients are female. We didn't really think about it that way before. I thought it was more male-driven disease. It's not. It's a more female-driven disease. So PAD is a marker for death with a 1-year mortality or major cardiovascular event rate of 20%. How do we change that? Well, we look at patients. This patient was a farmer. You can tell that because he has his farmer's tan right here, and he couldn't figure out why his foot turned red. It took him 4 months to actually get to somebody who could tell him that he had rubor to his foot, and he was having rest pain. He couldn't sleep at night because of this painful foot. This patient had developed this little black toe, and it took her over 2 weeks to get to see a doctor. And by that time, she infarcted the foot, the part of the foot here. This part died. And so I could clean out the arteries in her, but there was no flow anymore. There was no little capillaries. And because of that, she ended up losing her leg. Now this person was treated by a primary care doctor, a medical doctor. Now I'm not picking on anybody. I'm just saying that this patient had gangrene of his toe. I know they were treated because there's betadine on that toe, and they were painting betadine on the toe to stop the gangrene. But the natural history is for that is to become wet gangrene or infect, and then that will explode through the foot into the leg, cause sepsis and death. That's what happened to Jack Daniels. That's just interesting little trivia information. He kicked his safe and developed dry gangrene, wet gangrene, and died. And so we have to interrupt this cycle. A patient with gangrene needs to see a specialist to actually fix that problem. And this last patient, this is a sad story. She's a young African-American female, present with an infarction to her toes. This is all pink here because I revascularized this foot. The plan was to wait about 6 weeks to establish at least a healthy foot, and then we would do a transmetatarsal amputation with a podiatrist to save her ability to walk, and that was the plan. Now, she is a diabetic uncontrolled. She does have end-stage renal disease and is on dialysis 3 times a week, and in that 6 weeks, this foot died. But nobody called me. Nobody said, hey, there's a new problem. The other foot's turning bad. It was just accepted that, hey, this is what's going to happen to this patient. And it doesn't have to happen that way. And so I think there needs to be a lot more understanding of what PAD is. If we're going to affect the amputation rates in this region, 40% of all of the amputations that happen in the country happen here in the South. And we know that if you have claudication symptoms, PAD symptoms, your mortality is increased. If you have critical limb disease, 20% are dead within 1 year after that diagnosis. And by year 10, almost everybody's gone. So that's a hallmark of significant disease. Can we interrupt that process? I think we can. When we look at patients that have critical disease and they either get a bypass operation or an endovascular surgery compared to an amputation, there's a significant difference in survival. And so amputation suggests that there's a decrease in survival with amputation. In a Medicare data set that looked at patients with critical limb disease, after 4 years, 42% were alive and still had a leg. 3% were alive and lost their leg, and 54% were gone. And amputation is a marker for death. So if you have to have that surgery, it's a higher chance that you're not going to be surviving at 4 years. When we look at a 5-year mortality rate of all the most common known cancers, And we have lung cancer here, where it's very prevalent and is very lethal. And we have breast cancer down here, which is very prevalent, but not as lethal. Only 10% die at 5 years. And we look at people who are diagnosed with critical limb disease. More people die with that diagnosis of critical limb disease than all the other cancers by that 5-year mortality rate than lung cancer. Lung cancer is clearly the worst of all. But this has a very significant mortality rate associated with it, with that disease. So there is there's an estimated 20 million Americans that have PAD. In 2015, 2.5 million people were diagnosed with critical limb disease. CLI is a leading cause of major amputation in the U.S., with the South experiencing a 40% event rate. PAD is a marker for death with a 1-year mortality and major cardiovascular event rate of 20%. The majority of patients with PAD are asymptomatic or believe their symptoms are related to something else other than PAD. And the overwhelming majority of patients with PAD are underdiagnosed and undertreated. And so trying to bring this awareness, if we can make that diagnosis, call them PAD. You have disease, you have a carotid artery disease, you have gangrene of the toe, you have PAD. We need to treat you differently. And that's the only way we're going to answer this question, is how do we as a medical community get ahead of and manage this disease for our patients? We have to identify it. We've got to identify it early, and we've got to be aggressive in our treatment. And so we always say, no more about this process and no more amputation. Thank you.
I'm Mrs. Stone. I'm one of the nurse practitioners at Vascular Institute of Chattanooga. So Dr. Lassar talked a little bit about peripheral artery disease, and I'm going to talk about being evaluated so we can get it diagnosed. So peripheral artery disease, what is it? So as he mentioned, plaque builds up in vessel walls. Arteries then cannot carry blood from the heart to other parts of the body. So flow reduction can progress from peripheral artery disease to critical limb ischemia. Critical limb ischemia can lead to amputation, limb loss. And it is the leading cause, critical limb ischemia is the leading cause of amputation. Peripheral artery disease, as he mentioned, often goes undiagnosed until symptoms become irreversible. Patients often will mistake peripheral artery disease as just normal symptoms of aging. It's a normal process. Patients feel that it's normal to have pain in their legs or lower extremities. They feel that it could be joint related, muscle related. And if it's left undiagnosed, these patients are at great risk of complications. So early detection is key, and knowing what to look for makes all the difference in these patients. And these patients need to know risk factors and how they can control those. This is an acronym that I feel that primary care providers or any provider can make patients who are at risk for developing peripheral artery disease. They can kind of provide them this information. Flow. F is for the feeling of pain in your legs. L stands for the loss of sensation in your feet or in your legs. O stands for open sores that won't heal. And W is for weakness when walking. So what questions to ask? If you have a patient in your office as a primary care provider or as in any other specialty, if you're seeing a patient that you suspect could have lower extremity peripheral artery disease, ask these patients, how far can they walk before they experience pain and discomfort in their legs? Can they walk 100 feet? Can they walk a block? Ask these patients, do you experience weakness in your legs when walking? I have had many patients tell me that they experience weakness in their legs when they're walking upstairs or up a hill or up any type of incline. And they ask these patients, have they ever had a history of wounds that have been slow to heal? So, patients who may be suspected of having some type of carotid artery disease, ask these patients, do you have numbness or tingling in your upper extremities? Ataxia, amaurosis fugax. Do you have numbness or tingling in one side of your face or facial drooping? Symptoms of carotid artery disease can be absent until stenosis is severe. I had a patient a couple of months ago come in who had had an outside ultrasound, and luckily his primary care provider had ordered the ultrasound after the patient had reported that he was having only numbness and tingling in one side of his mouth and in one side of his throat. So, if a patient is suspected of having mesenteric or celiac disease, questions to ask these patients are, do you have postprandial pain or early satiety? Do you have frequent nausea or vomiting or food fear? So what happens with a lot of these patients is they become fearful of eating because they know shortly after eating they're going to experience the nausea, the vomiting, the stomach pain. So they will greatly reduce what they're eating or how often they're eating. And in about 70% of these cases, patients will at some point have experienced vomiting. And they will also have generally some form of weight loss, and it's due to just the symptoms and to just fearful of eating. Renal artery stenosis. So these patients, I had a patient just yesterday who had been referred to our office, and she had no idea what was going on. She told me that she had gotten a phone call after a CTA had been ordered, and they found out that she had a renal artery stenosis. She had no idea what it was, or even how it was affecting her. And she had had uncontrolled blood pressure for years and was on more than 3 different medications. So ask these patients, do you have uncontrolled blood pressure? How many blood pressure medications are you currently on? Do they have decreased kidney function? What was their last creatinine, BUN, GFR levels? And one of the leading causes of kidney failure in the United States is uncontrolled hypertension. So patients need to be aware of their risk factors because most of these are all modifiable risks that patients can control. Smoking, and I know that as providers we've all had patients who just say they cannot quit. It's impossible, they can't do it. But there are things available to help them. Patients who are diabetic, who have kidney disease, hypertension, high cholesterol, increased age, or if they have a family history of peripheral artery disease. What's in your control? And this is me just about every night at about 2 a.m. I'm guilty. And that's really hard for me when I'm telling my patients to stop smoking. And I will tell most of them, me telling them to quit smoking is very similar to someone telling me to quit eating chocolate. I love it. It's an addiction. It's hard to stop. But, patients who have significant smoking history, let them know there are things that are available. There are medications, Wellbutrin, Chantix, and there is the nicotine replacement therapies. Patients who have been prescribed Chantix by primary care providers, cannot tell you how many of them I've talked to, and I ask, did it work? Have you tried it? And they generally say, no, I'm not even going to try it. I've heard that it causes horrible nightmares. So I looked into that a little bit, and that does happen in about 10% of patients. But patients often won't even try it because of that. So we need to encourage those patients to at least try it. Give it a try, see if it works. Diabetes. Patients control blood glucose levels, maintain A1C levels, and choose healthy foods and stay active. All of those things seem very easy, but I know that, in reality, it's difficult. But a patient of mine a few weeks ago, type 2 diabetic, had significant lower extremity peripheral artery disease, and I asked him, do you know what your last A1C was? And he said, well, what is that? Obviously, he was not managing his diabetes. Toward the end of the appointment, of course, he said, you know what, I think my last A1C was 80. I told him I felt almost certain it was not, but we would look into it further. So, hypertension, regular BP checks at home. Patients, if they suffer from hypertension, they need to have a blood pressure cuff, some way of checking it at home. They're relatively inexpensive. Educate these patients. Tell them to check it. I know checking it every day is not realistic, but checking it a couple of times a week, that's realistic. Encourage them, healthy diet, exercise, take medications as prescribed. I can't tell you how many patients I'm coming across who just aren't taking medications. They don't feel that they need it. So, hyperlipidemia. Once again, healthy diet, exercise, reduced fatty foods, medication adherence, and maintaining a healthy BMI. When things are left untreated, these are some facts. As peripheral artery disease worsens, essential flow to limbs is reduced and can even be blocked completely. These plaques are the same as those that produce blockages in the arteries to the heart, which causes an MI. Sometimes patients don't put those two things together either. Atherosclerosis causes a buildup of plaque, which interferes with oxygen and nutrients necessary for cellular survival. Loss of vessel elasticity is termed as arteriosclerosis, while fatty deposit buildup is termed as atherosclerosis. And when risk factors are not controlled, patients need to know the bigger picture. What happens? Well, it leads to advanced plaque buildup, which can lead to heart attacks and stroke. It can lead to limb loss. It can lead to ruptures, thrombosis, and embolization. Be evaluated. So I know as providers we've heard it all. So when talking to patients about their risk factors, we've heard so many different reasons why they're not being controlled. So we've all heard, I can't take statins due to joint pain. Well, Repatha is an option for these patients. It is less likely to cause that, so it is an option. So these patients need to be made aware that there are other medications other than just statins to take to control that. And the patient, I've heard many times patients can't afford their medication. Multiple pharmaceutical companies offer patient assistance programs for patients who can't afford their medication, so this is always an option, and we need to look into that. And once again, I've had patients tell me that they control their blood sugar with diet. Also patient, A1C of 13. So it's a true story. So consider educating these patients on the reason why medication is helpful, and maybe talk to them as to why or what they consider to be a healthy diet. Things patients need to be aware of, and primary care providers or other providers need to make patients aware of who are at risk for PAD are, when they do experience symptoms, contact a provider, let them know what's going on. Contact us, no referral is needed to be evaluated. Encourage patients to engage in their health, managing their own underlying conditions. Annual PCP appointments are necessary. Patients, especially if they've got risk factors, they need to be seen. Patients with hypertension, hyperlipidemia. Annual testing is needed to monitor things we can't see. Patients don't always know that blood pressure is elevated or that their A1C level is elevated. So encourage these patients to engage in their health care and, once again, to take medications. Complications, what can happen? Well, if left untreated, it can PAD can progress from a small wound on the foot to gangrene. It can lead to limb loss. If left untreated, carotid stenosis can lead to a stroke. So looking into some stroke facts, there are 5 types of disabilities that can occur after a stroke. Patients can have paralysis or problems controlling movement, sensory disturbances, including pain, problems using or understanding language, problems with thinking or memory, and even problems with emotions. Stroke statistics. So after a stroke, approximately 30 patients will have no deficit. Approximately 30% of patients will have some form of deficit, whether it be paralysis, sensory disturbance, aphasia, or memory loss. And then 30% of patients after a stroke will die. And so I think patients need to be made aware of these statistics because they are somewhat alarming. Abdominal aortic aneurysm. So it's a bulging in the wall of the aorta. It can create a weakening in the wall, and if it's left untreated, it can result in a rupture or a dissection. I worked in surgery for a decade before becoming a nurse practitioner, and thinking back on all these patients who would come in the emergency room with a ruptured aortic aneurysm, it's 50-50. So early detection is key. So looking at the U.S. Preventive Services Task Force, what they recommend now for men ages 65 to 75 who have ever smoked, and ever smoked means they have smoked at least 100 cigarettes in their lifetime. I'm not sure who came up with that calculation, but if they have smoked 100 cigarettes in their lifetime and they're between the ages of 65 and 75, they need to have at least one screening for an aortic aneurysm. Men between the ages of 65 and 75 who have never smoked, it needs to be offered. It should be a selection. It should be offered to them. Let them make the choice. Women who have never smoked and they do not have a family history of an aortic aneurysm, screening is not necessarily recommended. But women, same thing. If they've ever smoked between the ages of 65 and 75 or have a family history, they should be evaluated by ultrasound. So takeaway points. Talk to your patients. Sometimes even they have trouble describing their symptoms. Think outside the box. When everything else has been ruled out, could it be vascular? Putting the puzzle pieces together can be difficult. I am even learning this. I've only been practicing as a nurse practitioner for about a year now, and it's hard putting it all together. So this is an actual presentation that I think most of the nurse practitioners at Vascular Institute have probably experienced. So a 61-year-old patient presents with pain in his hips, burning in the buttock area for 6 months that gets worse with increased ambulation or when walking upstairs. He also had occasional weakness in his thighs and in the left leg. He had a history of an old sports injury, lower back. He was non-diabetic, well-controlled hypertension, on a daily statin, and he was a previous smoker. He had smoked approximately 3 packs a day for 25 years. So he had been to ortho. They had checked out, all clear. It was not related to bones or joints. Neuro had ruled out any kind of nerve concerns. Rheumatology said it was not arthritic in nature. And he finally had a referral to us, and he had distal aortic and left iliac stenosis. So it took him a minute. I think it was about a year before he got to us. So, thank you guys.
Okay, I'm Ashley Elledge. I'm one of the nurse practitioners at Vascular Institute. It's my first year speaking, and I told Dr. Lassar he may regret me being on the microphone. So, I'm doing be tested. Okay, here it goes. I'm already messing up. It's upside down. I have no financial disclosures. So what does being tested mean? Most of everybody in this room, I'm sure, have heard about ABI testing, possibly angiography and CT scans, and so those are what I'm really going to focus on here. So really, where do our patients start? And most of the time, it's going to be in the primary care doctor's office visits, but you know, we do see a lot of referrals from cardiology, even orthopedic, podiatry, and really the early detection is the key, as well as educating these patients. So I'm kind of doing a different kind of approach with mine. I'm doing a lot of just kind of case studies. So this is a patient that just came in, probably primary cares get these same complaints, just generic leg pain. So he's a 68-year-old male patient, has a history of CAD. He's had coronary artery disease with stents. He's a history of smoking, had a history of stroke, but no deficits. He's just on the traditional medications that most people, I guess in this region, we see a lot. He's reporting the main common symptoms we see a lot: numbness and tingling in his feet. He walks a few feet, but reports his entire legs are hurting him. So, and he also has chronic low back pain, but attributes this to his work history. So, physical exam, we read the referring provider's records, and they had reported that the pedal pulses were diminished, but upon me seeing the patient, he had aortic bruit, and he also had decreased femoral pulses. So at this point, what testing did you order? And so the key things with this patient is he's having leg pain upon just immediately on walking. And anybody that's symptomatic, you can just start with an ABI. But also, even asymptomatic patients, if they have coronary artery disease, smoking, and diabetes, you can clinically go ahead and do an ABI test simply because of their risk factors. And then, of course, if the ABI is positive, you can send them to us, and then we can choose whether they, need an arteriogram. So, of course, ABI testing compares the blood pressures at the ankles and the arm, and again, we go a little bit in depth and duplex the arteries as well. This screen's a little busy, but this is from the ACC and HAA guidelines, and then kind of where those red arrows are, I'm not even going to try to do the laser because I'll mess it up, but those are just like kind of simple ABI kind of ranges that you can kind of target yourself. So, anything less than 0.9, that can be an indicator for disease. So this is the example I got for this patient. They had ordered testing for this patient. And I mean, can you really even interpret what is going on? There was no ABIs for me to really interpret, but because I work in vascular, I keyed in on, I won't do the laser. Oh, I did it. And these velocities are really low for this patient. They did do the external iliac artery, which is surprising. Not all outside facilities will do that, but the common femoral arteries on both sides were very low, and so that really just already keyed into me that there could be more of an obstruction above the belly. So if you get that from an outside study, likely you're going to refer them to us, and so you can refer them to us, or if you have a vascular practice near you. So we do our baseline testing, and it showed monophasic from the common femoral level down to the tibials. He had toe pressures, definitely less than 30, that indicate poor wound healing. So this is what our ultrasound really showed. There was really nothing common femoral down to the tibials. So at this point, I also keyed on the low velocities in the tibial. Velocities of the tibial shouldn't be in single digits. Again, that blood is really working hard to get down to those ankle levels. So because I had aortic bruit and decreased femoral pulses, I did aortic complete, and of course we found a right at the bifurcation and occluded aorta. So at this point, if you do, get an ABI with it showing monophasic throughout, you always want to think of obstructive disease in the aorta and iliacs. So this patient got a CTA with lower extremity runoff and is ultimately His iliacs actually were occluded as well as he had some collateral flow, so he's probably going to have an aortofemoral bypass. Okay, so here's just another case study, and this was a female patient, just diabetes. She was complaining more right calf pain than the left, but she was pretty well claudicating on both sides, and her pulses were slightly diminished. She got referred to us. The PCP did order ABI testing, and it was just kind of mildly decreased, but there was suspected SFA disease bilaterally. So our ultrasound we got, sorry these are kind of blurry a little bit, but definitely there was a diminished flow in the popliteal level, and then we ended up, because she was a claudicant, we moved forward with an arteriogram, and she did have an 80% right mid SFA stenosis and occluded distal SFA, so she had an atherectomy with balloon angioplasty, and she's returning in 2 weeks for the left leg. This is another study. This is a male patient. He had CAD. He's had spinal stenosis. He is a diabetic. The referral from the primary care was just numbness in the feet, and that was it. No other studies, which is fine. The patient, he was expressing to me more low back pain, occasional hip pain, but I was kind of getting more in depth with him, and he acted like the hip pain was more commonly happened almost every time he walked. But the calves didn't really bother him, and then burning and tingling of his feet. So I did studies because he was complaining more of hip pain. So I went ahead and did the aorta and his iliacs, and we did see a little bit of narrowing at his infrarenal aorta. But this is his waveforms distally, and so at this time, when you have a patient who's complaining of hip pain, you've got a little evidence of some aortic disease. The next step you can always do is walk these patients. And so I walked the patient. I went a little bit ahead of what I was saying. So this is the plan. I walked him. Immediately upon walking, I think it cut off the picture, but immediately after walking 5 minutes, his pressures never dropped at the ankle. So ultimately, this lesion at the aorta could just be calcification, and it's not a significant lesion to probably not cause his hip pain. So at this point, he could be having some spinal issues. So my plan was to refer him to ortho for possible workup and even a nerve conduction study. So ultimately, the take home here is just talk with your patients. Early recognition is the key. You could always order an ABI, and you could always refer to us if you're not sure. I will tell you one thing about me is when I first came here, I always asked a question almost every single day to Dr. Lassar. I'm sure he got pestered with that, but we're always here if y'all need any of us for questions if you're not sure. So thank you.
Good morning. My name is Stephanie Sheridan, and I'm the old head of the group, y'all. So I've been tasked with discussing and pulling all this together, what we need from the primary care practice and what we do at our office and how you guys can help us collaborate and take care of our patients. So be treated, the appropriate patient selection. Maybe not. And I'm a nurse practitioner at Cleveland. That's where I see most of my patients. So what we need to know is who is at risk for peripheral artery disease. Early diagnosis is very important and key, and our expectations from our primary care and what you guys are expecting from us as a vascular specialty and our medical management for these vascular patients. Well, we already know that Chronic diseases place these patients at a very high risk, the hypertension, hyperlipidemia, chronic kidney disease. And we know that as primary care providers, you see these patients and you know this population by heart. The CDC says that 8.5% of the population has peripheral artery disease, and 4 out of 10 of those patients are asymptomatic. So you're seeing these guys in your office frequently, and so you're able to determine who's at risk for PAD. We know that the elderly population is at a 3 times increased risk of having PAD, and we know that smoking is a vital component to the progression of this disease. So when you guys see them, we know that you guys obtain a HPI, because you're doing the same thing that we're doing, trying to assess what's going on. Also, the medical history of hypertension, hyperlipidemia, past family history of cardiac disease is all important and vital to this. I've noticed a lot of the Medicare insurance carriers are doing like monofilament tests in the home, and also you guys are going the extra mile in ordering the ABI, and so we already have that in hand, which is beneficial for our practice. So I'm going to take a moment to talk about what happens once you guys refer to us and what we see in our office. We love our case studies. It makes it easy to learn when you have evidence-based practice to use. So once you've sent them to our office and you have that patient that has uncontrolled hypertension for a very long time, and they just don't know what's going on. You've tried all kind of medications, nothing's working. This person has a past history of heart disease, diabetes, and her blood pressure is 178/89. She's on 3 medications, lisinopril, Lasix, and Colreg, but she's still hypertensive, okay? So in our office, we see this patient getting our history, and then we want to order a renal ultrasound. Our ultrasound shows, and I'm sorry that it's not very clear, but she has a 60% stenosis at the origin of her renal artery and the proximal. So her kidney size is normal at 10.68 and 10.8 centimeters, but she's on 3 medications. She's been hypertensive for years, so we order an arteriogram. Let me just show you a picture of the ultrasound. So there's the 60% stenosis. This is what we use when we treat. We can see the lesion right there. And then we do what's called an arteriogram. We kick this patient to Dr. Harris, and basically you can see on the left there's the renal stenosis that you can see. And then we place a stent in that kidney. And usually we tell these patients that to be careful, because once you place the stent and you have adequate blood flow to the kidney, when you take those 3 medicines, it may drop them out. So they've got to be aware of that and kind of know you may need to just, take 2 of those, but you also want to get back in with your primary care so that they can monitor those blood pressures. And I often tell my patients that keep a blood pressure log. It's really important. It's important when you come to us. It's also important when you go back, because then that gives you guys as primary care providers a picture of what that blood pressure is doing. Now, don't take it every 20 minutes, which my patient did yesterday. I was like, listen, you making your blood pressure high, please stop. Don't do that, okay? But like every 8 hours or so you have a range. Here's another case study. This patient is a 71-year-old gentleman with hypertension, diabetes, and he's a pack-a-day smoker for over 50 years. He's claudicating at 100 feet. Rest pain. My big analogy I use every time, and I always say it at these conferences, I use the Walmart aisle. And if they can't make it down the Walmart aisle, they can't walk 100 feet. Well, this gentleman, he couldn't even make it into the store to get in the cart. So that kind of lets you know where he is. Rutherford 5, which is a category, letting us know that this guy has rest pain and also has some tissue damage, okay? And then we obtained an ABI, and you can't see it, but he has multiple lesions. He has a SFA lesion, which is right there at the femoral, at the thigh region. He has a lesion at the popliteal behind the knee. And then he also has what we call tibial disease. You have 3 arteries that take the blood to your foot, your anterior tibial peroneal and your posterior tibial. So he has a blockage in his anterior and posterior tibial. And you can't see it up there, pedal acceleration time or PATs, but his PAT is showing some ischemia. So we take him for an arteriogram. What I didn't mention is before we were talking in the office, we like to make our patients take their shoes off so that you can see their feet, because he failed to mention that he had a black toe. That's what they call it, a black toe. But he has dry gangrene of his toe, which is Rutherford 5. And so this is a critical limb ischemia. So we gave this patient to Dr. Lasar because he likes to work in the tibials. And basically, if you look at the middle picture, you can see what the artery's looking like. You can see on that third picture where the posterior tibial right there at the heel is open and now providing blood flow to the toe. And I don't have a picture of the dorsal pedal, but we also worked on that as well. So as we look at our iliac patient, so this person that has a blockage in their iliac will have cramping in their hips and buttocks. And sometimes that's difficult to pull out because a lot of patients will complain of some lower back issues, especially as they age. But they also had diabetes, heart attack in the past. But we obtained an iliac artery ultrasound. And that ultrasound revealed that, one, they'd had stents before, so they had some in-stent stenosis, pretty significant, greater than 75% in the common iliac artery and external. And so we placed an iliac stent in there. And so what we want you guys to know is after we do arteriogram on our patients, we will always place them on a statin. And usually antiplatelet and anticoagulant status post-procedure. We know they're going to probably see you guys back before us because they should be seeing their primary care pretty frequently. Medical management for these people, yes, we definitely want them to consider smoking cessation. That's vital. They've got to stop smoking, and we try to work with them, and we do some smoking cessation in our office, and also lifestyle changes such as diet, exercise, a walking study. Anytime somebody has an arteriogram, we always encourage them to walk. And I know when they have blockages, they're going to say, oh, my legs really ache when I walk. But we want them to try each day to walk past that pain in the legs. We want them to control their blood pressure, their diabetes, and we will definitely be seeing them back most frequently. You know, our goal or our mission is to help with these patients and collaborate and avoid them getting amputations. We appreciate you guys working with us and helping us with this mission and improving the quality of life for our patients and allowing them to have victory over amputation. Thank you.